Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can talk about conversion disorder. What is conversion disorder? How is it diagnosed? How is it treated? And some other areas like that. I'll cover kind of conversion disorder from a few different angles. Now, whenever I talk about a disorder like conversion disorder, that really does require a physician for the diagnosing side. I like to point out that I have a PhD in counseling. I'm a professional counselor. I'm not a physician. And again, with conversion disorder, I'll talk about this a little later, but it's really important to have a physician's involvement. It's important that counselors cooperate with physicians in order to make sure that the client gets the correct diagnosis and gets the best care. Now, conversion disorder is an official mental disorder listed in the Diagnostic and Statistical Manual, the DSM. It's also referred to as functional neurological symptom disorder. Now, this disorder contains 4 criteria, as we see it listed in the DSM. 1 or more symptoms of altered voluntary, motor, or sensory function. Clinical findings that provide evidence of incompatibility between symptom and recognized neurological or medical conditions. So this is more than just not being able to figure out what's going on. So really, with this symptom criterion, this shouldn't be interpreted as an absence of a medical explanation. So that's not the symptom criterion, but rather, again, an incompatibility between the symptoms and what should be happening from a medical perspective. So another way of putting this would be the symptoms don't fit with the pathophysiology. The next symptom criterion is the symptom or deficit is not better explained by another medical or mental disorder. And the last symptom criterion is the symptom or deficit causes clinically significant distress. Now, this disorder also has a variety of specifiers that may apply. For example, with abnormal movement, like tremors, with special sensory symptom, so for example, altered, reduced, or absent skin sensation, vision, or hearing. We see with speech symptom, like slurred speech or reduced or absent speech volume. These are referred to as dysphonia and aphonia. So reduced is dysphonia and absent is aphonia. Other specifier examples would include with weakness or paralysis and mixed symptoms. And there's actually a few more in addition to these. Now, we also see some other types of specifiers. So we see acute episode. This is when the symptoms have been present for less than 6 months. And we see persistent. Here we see 6 months or more in terms of the symptom duration. There are also 2 specifiers about psychological stress, with psychological stressor and without psychological stressor. Now, with conversion disorder, the symptoms are real. They're real symptoms. The individuals can feel the different symptoms. They're experiencing them in reality. The person is not pretending. However, a diagnosis does not require a judgment that the symptoms are not intentionally produced. So the clinician doesn't have to make this decision that the client is not feigning the symptoms. But if there is clear evidence that they're feigning the symptoms, this points more strongly toward factitious disorder or malingering. Now, if we see something like secondary gain, this points toward malingering. So if somebody's pretending to have symptoms because they want to get something like money, usually we think of that as malingering and not something like factitious disorder or conversion disorder. Now, with factitious disorder, there's no clear gain for the client. They're not doing it for money. Maybe they're doing it for attention, but we consider this kind of an internal need. They're driven to perform these behaviors, to pretend that they have symptoms, or to do something that would cause them to actually have symptoms, like self-inflicted actions that would cause the symptoms. Now, sometimes with conversion disorder, there's a lack of concern on the part of the client about the nature of the symptoms. This would be different than factitious disorder, and probably different than malingering in most instances. Now, conversion disorder can be comorbid with somatic symptom disorder. Symptoms with somatic symptom disorder often cannot be determined as incompatible with pathophysiology. And again, the incompatibility is required for conversion disorder. Another difference with somatic symptom disorders, here we usually see excessive thoughts, feelings, and behaviors about the symptoms. We typically don't see this with conversion disorder. Another important differential diagnosis to conversion disorder would be neurological disease. People sometimes forget that conversion disorder can be comorbid with neurological disease. So a person can have neurological disorder and conversion disorder at the same time. The conversion disorder might explain some of the symptoms. The neurological disorder may explain other symptoms. As far as mental disorder comorbidity, it's not unusual to see someone with conversion disorder who also has major depressive disorder or post-traumatic stress disorder. We also see certain types of symptoms tend to be common with conversion disorder even though they're not part of the disorder, like dissociative symptoms, for example, derealization, depersonalization, and dissociative amnesia. We also tend to see a history of maltreatment associated with conversion disorder and maladaptive personality traits, like the type of extreme personality traits we see with personality disorders. Now, conversion disorder is a disorder I've seen in my clinical experience a few times. I've also supervised clinicians who had clients with conversion disorder. This kind of presentation really requires cooperation between the counselor, the mental health counselor, and a physician, often a neurologist, but I guess technically it wouldn't have to be. So this cooperation is important because this disorder really needs to be diagnosed by a physician. The diagnosis has a medical component to it. It's often treated by a counselor though, right? So diagnosed by a physician, but treated by a counselor. Interestingly though, conversion disorder can be thought of as a mental disorder and/or a physical disorder. One recent theory about this disorder is that it's actually, in some cases, an undetectable neurological disorder, and a lot of the mental health symptoms we see associated with it are technically separate or are caused by that neurological disorder. Now, to understand this a little better, we have to understand how the Diagnostic and Statistical Manual has described conversion disorder in the past. Now, in 1994, we see the DSM-4 came out, and we see conversion disorder was listed in that version of the DSM. And here, in terms of the definition, we see that this version required an identifiable psychological factor, right? So this was required in addition to a lack of a medical explanation for the symptoms. Moving to 2013 with DSM-5, we see that the psychological factor criterion is no longer there. Now, some researchers believe this really makes it too easy to diagnose conversion disorder. Now, they're of course talking about the physician side, not the mental health counselor side, because again, only physicians can really make this diagnosis. But what they're saying here is that at least some of the time, a physician believes an individual has conversion disorder, but there's actually a biological explanation that the physician cannot identify. Now, those that have this concern still acknowledge that conversion disorder is a real disorder. They simply worry that potential biological explanations are discarded in too many cases. So conversion disorder is controversial. One of the reasons for this I just explained, but there's another important factor to consider here. Some of the psychopathological diagnostic classifications that we have in the DSM are based on an older theory of psychotherapy called psychoanalysis, the psychoanalytic school of thought, which of course was developed by Sigmund Freud. This theory emphasizes the role of unconscious conflicts. What we now call conversion disorder used to be called hysteria, which of course is associated with psychoanalysis as well. The word conversion in conversion disorder actually refers to the functioning of a psychoanalytic defense mechanism called repression. So somebody represses their feelings, they push them down deep inside over to their unconscious mind, and those feelings are converted into physical symptoms. That's the theory anyway. So to give an example of this, say there's a woman who is raised to never behave in a violent manner. Violence is never acceptable to her. Somebody does something to her which makes her start to get angry. She wants to punch that person with her fists. But because that behavior is violent, and again, violence is unacceptable, that desire to strike the other person gets pushed down into the unconscious mind. So the woman never hits the individual, but that repressed feeling gets converted into a physical symptom. For example, her arms become numb or become paralyzed temporarily. In a sense, her psyche won't permit her to act on that anger, to act on that desire. That's the idea again behind it. Now, this explanation or conceptualization would not necessarily be problematic, except we can't actually prove that defense mechanisms exist the way they're explained in psychoanalytic theory. The modern version of psychoanalytic theory is psychodynamic theory. It's not necessarily a bad therapeutic modality. Neither one is necessarily bad. But having these modalities closely tied to the disorder, the way it's conceptualized, really makes some researchers a bit uncomfortable. Interestingly, this same understanding can be thought of without referring to psychoanalytic thought or psychodynamic thought. Simply, we can think of mental and emotional stress that gets presented as a physical symptom, that gets manifested that way. So it doesn't necessarily have to be the defense mechanism of repression. And this idea that stress can be converted into physical symptoms really isn't that controversial. Many people understand that stress can cause physical problems. Now, in terms of the prevalence of conversion disorder, we really don't know how prevalent it is, although generally we think of the prevalence as being quite low. However, the consequences for those who have conversion disorder are fairly serious. For example, 82% of adults who have conversion disorder will stop working because of the symptoms. In terms of treatment, I mentioned that usually the treatment for conversion disorder is delivered by a psychotherapist, like a professional counselor. One of the complex parts about treating conversion disorder is the initial presentation of the diagnosis itself. So how the counselor delivers the news to the client that the client, in fact, appears to have conversion disorder. The concern here, of course, is that the client is going to reject the diagnosis because they know their symptoms are real and they believe there must be a medical explanation as opposed to a psychological explanation. And, of course, if they reject the diagnosis, the concern would be that they won't stay around for treatment, or they will not participate in treatment with the necessary flexibility of thinking. There are some general tips in the research literature for approaching this particularly sensitive situation that clinicians may want to consider. Not all these are necessarily good ideas in every situation. Again, just general guidelines that we see. So the first would be confirm with the physician that the client actually meets the criteria for conversion disorder. This is important because, again, without the physician's input, the diagnosis really can't be made. Now, often what I've seen in practice as a counselor is that the physician will tell the client that the client has conversion disorder, but not offer a detailed explanation of what that means. The client really depends on the counselor to hear the long version of what that diagnosis means. So I think there are two reasons for this. Physicians are often pressed for time, and often they don't want to wander into a discussion about mental disorders. They leave that to counselors. And this really makes sense. It's just like mental health counselors leaving the medical discussions to the physicians, right? So as a counselor, I always leave those discussions up to the physicians. That's not my area. Each practitioner stays within their area of expertise. The next idea about navigating this critical juncture would be building the relationship during the first session and saving the diagnostic information for the second session. So really just trying to lead into the information a little more slowly. Build that relationship first a little bit, kind of understand each other a little bit, and then talk about the diagnosis and its implications. The next idea here would be to communicate with the client that you understand that the symptoms are in fact real. So avoid giving the impression that there's nothing wrong with the client. This can be really invalidating, and of course that's not good for the therapeutic relationship. Next idea is to provide examples of other disorders that sometimes have a stress-related cause. For example, adjustment disorder or post-traumatic stress disorder. The next idea is to point out that the symptoms are potentially reversible. Again, there's no neurological damage with conversion disorder, so improvement is possible. So this is really good news for the client, because if neurological damage was present, recovery may not be possible. The last idea for this critical juncture here would be point out that accepting and understanding the diagnosis actually tends to lead to improvement. This really allows the client to move away from the feeling of being stuck in a state of constant worry about what could be wrong. This is actually considered one of the most powerful techniques in treating conversion disorder, building acceptance and understanding. I've seen this make the difference several times. It can really be a turning point in therapy. In terms of treatment modalities indicated for conversion disorder, we don't have a lot of information about treatment strategies that might work with this mental disorder, but it does appear that cognitive behavioral therapy is effective for many who have the disorder. The last thing I'll cover here is in terms of the prognosis, right? So what about the prognosis for conversion disorder? A good prognosis is more likely if we see one or more of the following factors. A stressor that can be clearly identified. This makes a lot of sense. If you can see something that's causing stress for the client, that improves their chances of a positive outcome. If the person is functioning well before the onset of the disorder, we call this premorbid functioning. This points toward a good outcome. If the onset of the disorder was sudden, that points toward a good prognosis. And if there is a lack of comorbid mental disorders, like the ones I mentioned before that might be commonly comorbid, major depressive disorder and post-traumatic stress disorder, but also any disorders, right? So if there's a lack of mental disorders in general, again, that points toward a good prognosis. So that's my review of conversion disorder and some of the thoughts I have about treating it. I know whenever I talk about topics like conversion disorder, there'll be a variety of opinions. Please put any opinions and thoughts in the comment section. They always generate really interesting dialogue. As always, I hope you found this description of conversion disorder to be interesting. Thanks for watching.